Welcome, everyone. Welcome, attendees from Europe, Australia, and all over the world. And thank you for joining us on a leisurely weekend today. So I assume it's a bit late in Australia. It's about 8 p.m. And in Germany, it's about in midday. So thank you for joining us on your weekend and sparing time for a discussion like this. Well. The Global Health Hub Germany is an organization that is based out of Berlin, and it's funded by Ministry of Health. And this particular panel discussion is being organized by the Global Health Hub Germany's Working Group on Ethics and REPROGRAM Global Consortium. And we are very pleased to have this discussion today on some of the burning issues during and beyond COVID-19 in global health. And the question that comes to my mind is that why is this discussion relevant? Why we have come to the point that we have to debate about humanities and medicine? Well, this is our attempt to connect global North and global South, and to connect medicine and humanities. The question is, how can humanities and medicine inspire each other to define a new spirit of global commitment to health, to full and sustained responsibility, solidarity, and justice for all? As you know, that global health narratives maintain a self-sustaining bias, perpetuating the weakness and dependency of global South and the capabilities and entitlement of the global North. And of course, you would recognize that there's a lack of critical self-reflection and respect on the side of the global North that warrants attention and is a part of the problem. Well, today we will discuss some of the burning issues on health equity and quality that exist across societies, and why some of the interventions that we think are going to work in the global South don't optimally work, are not implemented properly. We'll also put forth some conceptual ideas and the need to reform global health mindset. Well, today, this session is an open discussion, and please, we welcome your comments, so please feel free to use the chat box to make comments or to ask questions of our panelists. This is a safe space. A good idea can come from anywhere and from everywhere. Let's be inclusive of the diversity of thought, and let's learn from each other's experiences. Now, let me welcome the panelists today, Dr. Ole Doering. Dr. Doering is the steering member of the Global Health Hub Germany in Berlin, and one of the thought leaders from Germany who really have looked into the malice and the good of philosophy and how philosophy can guide our understanding of medical aspects of humanities, but also how that can be applied to the society broadly. So, Dr. Doering, if I can start a question at the beginning, I think our topic is igniting global health. Why that ignition is required?
Thank you very much, Dr. Bhaskar. I just realized that I have some technical problems. So if you can't hear me, please indicate by waving or something.
We can hear you. We can hear you clearly.
Very good. Thank you so much. Yes, my name is Ole Doering, and I'm a philosopher and sinologist who's been working on philosophy, ethics, culture, and health for decades now. I'm also a co-founder of the Berlin Institute for Global Health, and I'm happy to see that my colleague, Dr. Bonk, is also here in this room. So we will have a lot of valuable input from his side as well, hopefully. Yes, why igniting? Dr. Bhaskar, we met in Berlin virtually, not really, but at one of our working group meetings where we focused on justice and vaccinations. And well, I must say that this process of building a global health community is very rewarding. It's like washing gold. And the gemstone that fell into my hands there was to everybody here, Dr. Bhaskar, because I was so impressed by his intense engagement as a doctor, as a health specialist, and a social activist with a clear sense of ethics. And well, we came into a discussion, if I recall properly, by asking ourselves, well, what can we actually do? And this is now the question that connects the academic world with the layperson's world, with everybody's world. So we have only one world, and we want to make this clear that we can only make it healthy through action. So what kind of action is required? Of course, as a humble academic, I can only bring in and suggest and propose and inspire thinking, argument. And so what we have at our disposal as academics is reason, the force of reason, the capacity of reason. And this is more or less the specter of the humanities. Now, when we get back into the history of health care and medicine, it has always been much more deeply related to the capacities of social skills, empathy, trying to alleviate suffering, trying to understand what a healthy, good life means. This is not only in the ancient past, it's of course the founding of modern medicine in the 19th century. If you recall, Rudolf Virchow, the famous professor at the Charité, he was very clear that medicine is a political agenda, and it's not restricted to any national objective, but it's it's a humanities agenda in the long run, hopefully. Now we seem to have forgotten all about that. Okay, why igniting? You asked. Why igniting? Let me put it this way in a little bit of a personal story. 1 year ago, it was maybe in March or April last year, 2020. Some people believed in Germany here that this crisis, the COVID-19 crisis, might serve as a wake-up call, slowing down the crazy, waste and harmful way of life, making medicine about health, acknowledge the social interconnectedness of the global village, not only as a market. This, at that time, seemed to appeal as an opportunity to move forward. Of course, in Germany, we have this luxury that we can think of these challenges in that way because, well, we are wealthy, we are healthy, more or less, and we are hopefully educated. Now, this big picture held a promise to improve health services and education, to address non-communicable diseases, so as to build resilience against epidemic potentials of those more difficult diseases to contain. To respect diversity of the capacities all over the world was one of the hopes, to bring them together, to organize global health individually through health and education systems. And for a moment, this seemed possible, that we should not just care about disease in terms of understanding the pathogenesis, because we saw that caregivers on the streets were hailed symbolically. Underprivileged working groups or classes were honored and even awarded for, well, doing their jobs in spite of all the hardships. And the National Ethics Council of Germany called for a social debate on lessons learned to come. Well, that was a glimpse of hope, but in reality, if we now look today at the media, we seem to be back to the bread and games situation, where we are happy to go on holiday, no matter the costs. We are happy to enjoy the vanities of the soccer championships. Why? Why did we fall back to that? Why didn't we pick this up? I think it has to do with forgetting two things. First, we forgot about the rest of the world. We just forget that we are in Europe, we are only making up a small percentage of the world population, and our luxury are paid on the costs of the disadvantaged populations of this globe for many decades already. The second is that we have forgotten that we have set ourselves a promise, that is, with the Sustainable Development Goals, the SDGs, as a reference to build a new healthy global system for us all. We forgot these two things, I think. Now, this could call for the situation, could call for, justice. Of course, we talked about justice a lot. But I think we have to be more fundamental here. We should really ignite our passion for reason and not to just follow the impassionate rationality of the health services. We should really focus now on salutogenesis, understanding what makes the world as a whole, as a big interconnected global village, healthy through solidarity, and not by exploiting pathologies. We need to really think about cooperation in care above, across the silos of disciplines and professions, making ministries and institutes work together across the board to reform economic drivers so that they can support health capacities. Everything here is political, but it may never be politicized. The stakes are just too high to be politicized. We really have to work as honest citizens together. Finally, as a citizen born into one of the most privileged countries in the world, I feel ashamed. The shame lies in the profound inability to make a difference for the better. Because in Germany, in spite of all the rhetorics, I can see no structural development towards opening up to real collaboration with all the people worldwide. Although we have the knowledge and the capacities, these are very obvious in the setting of the Global Health Hub in Germany. We have wonderful individual capacities here. We have very well educated and broadly experienced health experts who are very well versed in collaborating with countries across the globe and who are just as despaired and ashamed as I feel myself today. Now, why did it come to this? I think it's basically a historical development. Healthcare originally rooted in the ethos of humanities, to make all knowledge and skills available in order to alleviate suffering sustainably, not just for the kind of 1 year or so of horizons. But this holistic social service approach, which I refer to in terms of the salutogenesis, was gradually replaced by the fixing industry. I owe this term to Dr. Bhaskar, who brought it up, and I think it's very, very well put. The fixing industry has a totally different mindset and a totally different organizing structure. So the task of treatment and advocacy is taken over by medicine in a narrow technical sense now. The rationales of organization, transaction, and so on are dominated by commercial rather than economic principles that support solidarity. The ways in which we organize our international regulatory system are absolutely Eurocentric. They don't really pay any attention to the realities in the global South. We just had, as part of this group, as the ethics group in the Global Health Hub, we just had a few days ago in German language a discussion about, well, what do we do in order to enable our researchers who receive public money and go abroad to do medical research and health-related research? What are we doing in order to help them to avoid double standards, in order to make them alert and sensitive to the needs and the special situations in these different societies, and then to learn from our experience, because perhaps this is the most unsustainable way in which we are dealing with these experiences, is that we are not really learning from them. There's no effort to learn from all the wonderful experiences, all the great models that we have already built and established and learned and experienced, how to bring them at a higher level of effectivity and efficiency. So I think these are some of the ideas that come to my mind as a humble philosopher that I am, with no specialty in medicine except for the philosophy ideas, but I hope they will inspire some discussion here, and I'm sure, Dr. Bhaskar, you will intervene now and say, well, this is all very academic and very nice, typical European perspective. Okay, let's make more sense. Thank you for listening, and I'm very grateful that you're doing this with me here.
No, I love the fact that you mentioned about the pathophysiology, and because off late with the advent of this extraordinary reliance on technology and artificial intelligence, I think we tend to forget that at the end of the day, patients are humans. So disease itself, we tend to biomedicalize treatment and medicine, which is really about getting the patients fixed. But unfortunately, the patient experience there gets a secondary seat, and I think it's important to bring that understanding of salutogenesis, which you referred to in your discussion, which is really about understanding that the patient comes from a wide variety of social determinants of health. I can give you from an experience from mine, so a patient coming to stroke in the southwest of Sydney predominantly comes from a more lower socioeconomic background, because the southwest Sydney constitutes predominantly of a huge population from linguistically and diverse background, and they come from all parts of the world, including many immigrants and refugees. Now, we looked at some data set on what are the patterns of these patients that are making them come to the hospital or avail stroke facilities at a delayed time point. And what we found was astounding, was that some of these patients are fearful to reach the hospital, to call an ambulance, not because they think that they probably think because in their respective countries, they had to pay for these services. So even though we have a social healthcare system here, the attitudes towards or awareness towards availing those facilities are quite stark in between the populations in the north of Sydney relative to the south of Sydney. Another interesting fact from the Cancer Australia recommendation was that if you look at the access to cancer health services in Australia, in Sydney, New South Wales, the outcome of patients with cancer really depends on the postcode of that patient. So how sad is that reality, that the postcode of a patient defines the outcomes that the patient will be getting. And that's predominantly because we have, for a longer time, unfortunately, the blame also has to be taken from the medical fraternity, that the model that we have developed is a biomedical problem, wherein the biomedical problem can help you understand, diagnose, and probably give best of treatments to these patients. But the patient in itself doesn't come in a black box. They come with a subset of ideas. They go back to the same home. They have the same problems at home. They probably live in a lower socioeconomic neighborhood. They probably are have not sufficient money to buy medicines. And poverty as a determinant of health outcome is a major tool de la force in these pockets. Now, we are talking not about Africa right now. We are talking about Sydney, Australia. Imagine if you transpose these equations down to the global south, these inequities become more and more stark. Now, as somebody who has dedicated my life serving communities around the world, I would not say it's been my passion. I think it's been my privilege to serve the communities in Africa and Asia. During my medical humanitarian missions in these countries, I always thought that I have learned more than I can give. And those learning have made me a better physician, not the other way out. I think that humility in physicians have taken a big hit over time because of our over dependency on biomedical solutions to the human illness. And that's why, from that particular logic of understanding human disease or diagnosing a human disease using an MRI scanner or CT scanner, to moving into a more transformative approach where we can think disease does need a diagnosis, does need a treatment, But as physicians, we need to take a better role of not just being the people who are the caregivers or the one who provides treatment, but also who are advocates of patients. So moving the debate from just being there as a provider, which, as you know, unfortunately in the Western world, the definitions of physicians have turned into a commercial provider and taker relationship, which I think is important from financial perspective, economic perspective, but has taken away the sheen and the humanity out of it. We need to bring back the humanities where we know that the patient and the caregivers do have the confidence in doctors, in nurses, and the healthcare providers, that they know that the best of care treatment are not just being given, but actually realized and felt by the physicians. That the physicians who are giving these treatments have the best interest of patients. Now let's go back to a few decades or centuries ago. The father of modern medicine, Sushruta, who was a great physician, he used to do rhinoplasty surgery. After the wars, a lot of patients used to lose their earlobes and the noses, and he used to do the rhinoplasty surgery on by himself. And at that time, many of the people who reached out to him, he said, "Why do you do these things when it doesn't give you economic benefit?" And he said that I didn't enter the profession because to serve myself, but to be an advocate and the one to provide the best of care for the patients who are very vulnerable. As physicians, we do have a sense of privilege. Why? Because those who approach us in their capacities are very vulnerable. They come to us at a position where their economic, social, emotional determinants are compromised. They cannot advocate for themselves. And if they can advocate for themselves, they want you be on their side. So I think that moving that equation, or shifting that equilibrium right from the biomedical perspective into the humanities problem is so important. That also brings me back to your question, Dr. Doering, that why humanity is important. Over last few decades, because I come from a developing country, from a very multi-ethnic and from a very humble beginning, I've seen that over time that humanities used to be the focus of our families and our growing up. And I think that humanities have taken a secondary seat because many of the medical students are given this understanding that humanities are not well paid, for lack of words, if you understand my drift. And medicine probably is a much more lucrative profession. I think there's a fundamental flaw in that understanding. What would be a medicine if not because of humanities? Our definition of medicine started with many of the conversations between great physicians of that time about why medicine is relevant to human society to reduce suffering and vulnerabilities of patients. That also brings to my mind a discussion which I had in Copenhagen, that at the time of World War II, if you remember, that people think that the medical ethics was found by the Helsinki Declaration. It's not true. The definition of the medical ethics, much more in the contemporary world, arose during the Nuremberg trial in Nuremberg, Germany. And I would give that credit to Germany for facilitating that discussion, which was actually about really understanding that if the excesses against the Holocaust victims have happened, why so? And if those excesses have happened from the physician community, can those doctors be held responsible for the actions that they have undertaken or perpetrated on their victims? And I must give credit that in that august society, that deliberations that ran for days, the Nuremberg trial records are online. You can actually read and go through those trials that set the foundation of what medical ethics should be. That, in our pursuit to understand biomedical excellence and innovation, we must not forget that the patient consent and patient's well-being and patient's best interest should be at the heart and left, right, and center of our debate in medicine. So I hope that answers a bit of a question there, Dr. Doring. But I would let's go back to you on a very another important question. I think you have touched base on it for a small point of time before. Why do you think that COVID-19 has brought that debate again? Because you see that in Germany, when I talk to my German colleagues, they tell me about that, that despite being the developed world, and same in Australia. I mean, as I speak, in Sydney, we have another flare up, and hundreds of patients are COVID positive, and the country is in a spin right now. So, as a developed countries, from the global north perspective, what do you think has made us to fail, and what can we do to improve our understanding of those failures, and what can be done to bringing the humanities in that debate to understand and mitigate those failures? Over to you, Dr. Doring.
Well, thank you. There are so many things that you mentioned that I would like to come back to, but I'll first try to answer your very, very good question. I think in the big picture, we can just say, well, the problem comes because we have forgotten the humanities and why they are so important to make sense. Humanities are there to organize discourse about making sense, and we have forgotten about history, especially history of medicine, because we have been able until a few decades ago to not only deal with but also to determine public health challenges such as major epidemics or even pandemic developments. In the early 2000s, in the following of the SARS-1 crisis, Germany was still very resilient and very well prepared, more or less, of course, in the big picture, to deal with these questions. And we had an infrastructure that was not comprehensive, but that was reasonably well equipped to organize public health services properly. And we had an infrastructure that allowed the logistics for at least producing some of our basic medical devices at home, so that we can really have them at our disposal when we needed them. But for some reasons, and we can elaborate the reasons, but they are somehow political, the interest in keeping resilience as a kind of social value that is very closely related to solidarity and to the non-positive and non-material aspects of health. This is understanding that medicine and healthcare are just a holistic approach and cannot be commercialized and cannot be administered by policymakers or their staff in the ministries, but that it has to be done by the professionals who have the resources. And I'm not talking about money, I'm talking about time mostly. We have more or less defined time out of our health system, time for care, time for attention, time for reflecting the bigger picture, time for caring about individual needs. And this, of course, accumulates to a huge sum of inaptness when we are challenged by these. Well, I think COVID-19 is not a major, extremely new kind of event. It is one of the epidemics that you human beings have caused, and because of our human lifestyles, it totally went out of control. Why? Because we have not listened to what we know from history. We did not look into coherence. Coherence is another of these, well, seemingly technical virtues or principles that allow us, in fact, to be whole. But look at how diversified the responsibilities in the health sector are in Germany, how poorly they are defined, and how little the backup systems are kept. We have a national department for crisis prevention and crisis reaction that also had the task of dealing with major national health crises. We have demolished that one. We are totally depending only on the Robert Koch Institute, which has a slightly different purpose. So I could explain this in more detail, but I wanted to draw a big picture. So many things come together that don't work together. So we have so many instances where we fail to mobilize and make salutogenically effective all that we can and that we know about health. And so because this is a systemic problem, we cannot look into each of these examples without raising contradiction, but we can see it now. Our schools are absolutely not prepared. First, on the conceptual level, nobody understands anything about the medicine and the biology behind this virus now, because it's not taught in schools. And also the infrastructure of the schools, that when I was a child, we could get vaccinations at school, we get TB checkups at school, and all these things, they're all gone. So the state has withdrawn from these infrastructures and left them to self-organization or to or outsource them even. And this has sometimes some good reasons, but in effect, it was mismanaged so that it was only serving the purpose of saving public funds. So if we save public funds that would build education and health, then of course you can't build resilience in a global scale. Now, and I would just like to make one brief remark about one of the points that you mentioned, which I think is so striking, that is that the postal code may define your health outcome or your health opportunities. If this happens in developed countries like Australia or Germany, if this happens there, well, we might have access to all the relevant knowledge in our countries. We failed to use that. So how can we be a model? How can we pretend to be able to tell the world what would be a good model? Why not find a way, set up a huge foundation that only provides knowledge and offers it for free to those countries that are determined to build their own system from scratch? I think this would be something extremely feasible and extremely necessary, because otherwise we treat people in these so-called developing countries, well, like immature children. And this is absolutely inappropriate, especially because, especially as my personal belief, is that if we allow everybody to do their own thing as best as they honestly can, there will be something new for others to learn from this experience. So we really need to reverse our logic of giving aid and providing, well, also all sorts of support. This argument has been made very often, so I don't repeat this here, but instead focus on where are the grassroots. And this is why I so much admire your work in the Rotary and other charity functions, because I think you have the right level, the right social level. But of course, who cares? The people in power don't. So how can we get out of this problem?
Thank you, Dr. Doering. I think that really brings us back to the discussion of why we started. And I can show you that Rotary as an organization, and it's all about individuals who are passionate about and service above self, which is, going back to the community and serving in whichever capacity one or he or she can. And coming back to your second comment about that, why a global organization can serve as a, for lack of words, a knowledge expertise or a pool of knowledge to serve the community in the global south is so important. And I think that is why we needed a organization like REPROGRAM Global to be formed. So REPROGRAM Global is an international consortium of about more than 150 physicians and passionate social activists from around the world. And we have about 30 countries cutting across the geography from the global north to the global south. And all of them are passionate about one thing, which is to give back with a single point of view that it's not through giving, but through dialogue, you achieve the best outcomes for your communities. So as we speak, tomorrow we have the Reprogram Global Western Africa initiatives debate with the senior ministers, the community leaders, the faith leaders in 3 countries in Western Africa, the Guinea, the Liberia, and these are the 3 countries which are connected by the river Mano, and that's why we have called this a Mano Africa initiative. For last 1 year, what we have done is to initiate debates with those who care and those who matters. So we have gone to the local communities and we have gone all the way to the ministers at the political level, brought them on the same platform in different tracks. And out of those tracks have emerged great consensus about what can be done to heal and to address the challenges that the COVID-19 has put forth. Now, let me give you an example of figures from the Western Africa. As you know, the Liberia, Sierra Leone, and Guinea, these 3 countries were really dilapidated after the Ebola crisis, the Ebola pandemic. And you were right when you said that the pandemics are nothing new. It's true. COVID-19, unlike previous pandemics, did affect the global north, and that's why it has become a pandemic of such a global proportions. But we have forgotten that the global south has been reeling under the pandemics for several years. Ebola crisis literally broke the backbone of entire Western Africa. Give you another figure, about 513 healthcare workers died during the Ebola crisis, a country which is already had acute shortages of healthcare workers, were now had a crushing fear the patients will have an epidemic of a proportion that we cannot imagine. COVID-19 has further broken the bones of these countries. When I was speaking to the physicians there, they shift from one point of, so they go to 15 different clinics in a single day, and they got hundreds of patients waiting in the outpatient clinic to be attended not by the physician, by a physician assistant because of the shortages. So, I mean, we are talking apples and oranges when we compare them with the developed world. I think our understanding of these countries and communities has been suboptimal, not because we don't have knowledge, because we have stopped the dialogues with these communities. I think once we understand their problems, make heart-to-heart understanding of their problems, will be in a better capacity to heal and work together, not in isolation. It's not about doing a survey from Berlin in the Monrovia, which is the capital of Liberia, that I am gonna do a health systems resilience framework. But problem with these frameworks are they're scientifically and academically excellent, but doesn't work on the ground. Because these frameworks will be surveyed by paid subscribers to people who have access to phones. But you have to understand that many of the communities in these countries don't have access to phones. So you are getting a survey of the elitist, of the few, of the most underprivileged communities. Is that a representative sample? Of course not. What do we get out of that research is that data are spurious. The data that doesn't understand it might understand the pathogenesis, as you have talked about. It doesn't understand the salutogenesis of the populations that we want to serve. And I think it brings back to our debate about when we started this discussion that we need to reignite global health because we need a complete shift in our understanding and mindset of global health, which is to decentralize global health. Give you another figure. About 70% of the leaders from global health organizations around the world are from global north. Now, let me repeat that. 70% of the global health leaders come from global north. And 80% of them come from high-income countries. They are probably 10% of our population, of the world population, but overrepresented. These are the people who make decisions for global south. These are the frameworks that get implemented. the vaccine frameworks, the frameworks for global health systems, the frameworks to fight pandemics, the frameworks for infectious disease preparedness are then implemented in the global south. Has they achieved? They might have, but are they applicable and rather conducive to the environments that we want to serve? If that was the case, then we probably would have no poverty or no disease in Africa. Or you would have a situation where they would be prepared to tackle pandemics like this. Why the countries like this are now reeling in shortages of healthcare workers? I was talking to another healthcare worker from Liberia, and they said that to get an aspirin, just one little aspirin, they have to ship these products from India. So they're getting these products from India because there are shortages of medical supplies, basic medical provision in these countries. So the supply chain has completely been dismantled. And of course, during COVID-19, that has got exacerbated. I think it reflects on the psyche of what the global health has been over decades. It's been a majoritarian approach, a top-down approach, which has its merit, but it does take away the organic part of medicine, which is dialogue, which is about advocacy, that the populations that are the people, the communities, the patients that we want to serve, we can do whatever we want. We can do probably 15 tests even before the patient talks. And that's what is happening. The biomedical journal BMJ had a report that more physicians are likely to talk less than 30 seconds to their patients. Now, what does that tell about our model of treating patients? We don't listen to our patients. We don't let them talk. We don't let them understand what the problem is. But we understand that we are the best saviors of our patients. The very definition of that saviorship is about, I know everything and you know nothing, and I'm going to give you what you want. I think that particular system and understanding has worked to the detriment of the global north, and it has funneled billions of dollars of money in the global south, much to the chagrin of these communities. They hasn't built infrastructure there. They have deteriorated those systems. Rotary has now a working group to look at why the healthcare equipments that are being sent to the global south are not being used by these hospitals. So a great MRI scanner is being sent to a little country in Liberia, but it hasn't been used for 5 years. Why? The reason being, you might have provided such a big equipment, but there is no electricity in that pocket. So the supplies, over time, the technical difficulties takes down the entire system. So understanding the geography, understanding what the population needs are so important and poignant in that regards. Well, I think we have really discussed about the problems, Dr. Doering, in this part of our discussion. I think it's a great time for us to move on to the next part, which is about what are the conceptual frameworks we can provide to challenge what has happened before, address the deficiencies in our approach to global health, and what we as a philosopher and doctors can do to understand and better heal the communities that are being ravaged by the previous understanding of global health. Over to you, Dr. Doering.
Yes, thank you. I think I will not be very innovative here because we know everything already. We just have to deal with that knowledge properly. We need to make better sense and better use of the things that we already know and that we are repeating and repeating all the time when we're talking out of the window. But we have to build our education system. We have to build our management systems. We have to build our economies according to that insight. If we are determined to say that health is one of the top priorities, the fundamentals of a society, together with education, then everything else falls into place if we take it seriously. But we're not used anymore to really address the matters of integrity, of being serious about implementing a program for all it's worth. I just want to come back to one of the things that you just alluded to, and just for clarification, perhaps, when you said that 70% experts are from Global North, and this is, I think this is not so much an issue of representation. When it comes to authority, I mean, legitimate authority, then representation doesn't really matter. But of course, it's telling, but it's not, the point is not representation, because this would make it a power issue. This is a power issue, but not in terms of health. It's a power issue in terms of the political interests. So what is it about? It's not about representation, but it's about attitude and qualification. These are much harder to measure and much harder to ascertain in a kind of objectively standardized way. When you say, well, saviorship, yes, I know and you don't. This is a matter of power, yes, but it's also a matter of character. It's a matter of character, about sincerity, honesty, and they are totally right. It's about listening. It's about being prepared to listen. So I think rather than offering new principles or new concepts, no, we don't. Each country, each culture has a lot of genuine insights into what makes them healthy. But nobody cares. Nobody now, in terms of the people who should care, they don't care. Maybe they don't see the point. They believe there's in fact one monocultural approach to these diversities of health realities, or they lack the conceptual coherence of a real philosophical system that allows both openness and clear definition. And as I just said, when we take it very seriously, when we say that all our resources should go into the basics of human needs, and these are health and education, because they are mutually depending, then all the things that come in by ways of supporting these goals will automatically or by default generate the system that we need. So we should not talk about a top-down thing. We should talk about a bottom-up approach, where we have an inclusive, encouraging, salutogenic, if you want, principles that, first of all, make everybody listen. And then second, economically, in terms of economy, it's not in terms of getting rich, but about getting the household properly organized. And now we're talking about the household of the global village. So we will need also here to set the wrong incentives, to remove the wrong incentives and set the proper incentives that benefit those who are doing medical and health work, and not those who are just serving in terms of fixing. And I think this would be a good starting point. And if we establish such an approach that people are serious, the system is integer, we don't lie and cheat about what we're doing. And if I look into the German system, as I said, we pretend to be a model. And in theory, we might have been a model until the 1990s, perhaps. But even this we forgot about. Now we have a totally dishonest system, in that most people believe that they are paying into a solidarity-based fund where everybody gets what they need and will contribute what they can. But huge shareholders just take all the benefit out of the system. I believe this is unconstitutional, and we have this sort of problem in Germany, where we know better and we can do it better. Now, we can't serve as a model here. What we can do is to say, okay, we have the same problems in general, like there are power plays going on globally that we are too weak and too slow to respond to properly. So the only thing that we can do is to be very humble and try to inspire others to have a grassroots approach, to build their own salutogenic approaches to building health system, and then allow them to do that and support in an idealistic manner, with knowledge, with stretched out hands, and with respect, eye to eye. We want to learn from you. maybe more even than you can learn from us, because you are new in this field. So this is exciting as well. So this is maybe, it's not a very, well, not a very fancy response, maybe a typical German, kind of very serious. But anyway, this is the best I can get.
No, thank you, Dr. Doring. I think one of the fascinating things which I love about Germany is the honesty and self-reflection. And I'm very sad to hear from you that that self-reflection has gone over some last few decades. And I think it's probably time for self-introspection then. Well, the reason I asked you that question was because from my experience, as you have said before, the listening really helps. So understanding that the grassroots movement doesn't start if we don't understand the problem, which is really about talking to people, understanding what their needs are. They probably don't really invest themselves in getting the best of world-class treatment. For them, the experience of that treatment is more important. And if we don't understand that, then we'll probably be addressing the inequities which has existed till date. Now, from my perspective, now I don't really have a recipe just like you, but I want to be honest as well. And here a few of my understanding, and of course it comes with a caveat and disclosure that I'm just a small soldier in this huge global health discussion. But I think every stakeholder in that discussion does have a voice, and that voice needs to be heard. Now, from my perspective, my understanding of global health has been, I think at every point of time, if we can self-reflect, as in the position that we are taking, is it the position of a privileged? Is it the position of power? And I think the answer that will come back to us is the power comes a very top-down approach. It takes away the humanities, which we started the debate with. So really putting people right at the center of our debate is so important. Putting patients, communities, and really getting them at the core of our debate is important. Second, from the community initiatives that we have been participating in before, one of the experiences I had, and I want to share that experience because it's an anecdotal experience, but tells us about what the healthcare systems has been. Late in the night, a couple of years ago, I was at the train station, and an elderly, frail gentleman was, in Australia, we have these Opal cards, which are these, tap on, tap off cards. So to get into public transport, you just have to tap on and you get inside. So my train was about 10 to 15 minutes later, and I was standing on the, not inside the platform, but outside it. And I was waiting for, just to get probably a Coke or whatever. And I found elderly gentleman tapping on and off multiple times on that entry gate. And he was doing that with a lot of people watching him and laughing about it, that what's wrong with this gentleman? And he was tapping on, tapping off, tapping on, tapping off, tapping on, tapping off. Now, as somebody who is a neurologist by training, but of course, my passion has been to community service, because I go out in communities and listen to people. For me, it was starking that many of the people in the community at that time didn't realize that a person may have the early signs of dementia, Alzheimer's, which is engaging in repetitive tasks of mundane order, which you and me won't do that. And so I reached out to the gentleman and I asked him, where do you want to go? And he said, Liverpool. And the question was that we were in Liverpool and he wants to go to Liverpool. So I understood what the problem was. And I told him, no problem, we will go to Liverpool. Can you tell me what's your address? So he said, no address. I have a phone number in my wallet. I would really appreciate if you can call that number. So I took the phone, called, it was his son, and then got him down to the Uber. And from there, I talked to his son and he gave me the address, and Uber probably took him there. Now, what does it tell you? Two things about us. That as a community, we have become insular and become apathetic towards individuals who are stigmatized either with a dementia, Alzheimer, or disease So if you got cancer, that's it, you got Alzheimer's, you got a neurological condition, and we think as an individual, we kind of disease phenotype them. We understand that individual as a diseased individual. But we take away that humanity and the dignity of that individual to live with respect and self-dignity. And at this conversation, this anecdote was really to share that as an individual, as community leaders, how important for us to listen and educate people in the community that small movements, small conversations can have dramatic impact on how we perceive and address the challenges that we have in the society. Now, from the recipe perspective, I really don't have a recipe for global health, but these are some of my thoughts from a global perspective. I think we need to work in three approaches, one at the individual levels. Individually, you, me, physicians, philosophers, we need to talk to each other. We cannot let this mantle be taken by those who are invested in the commercial determinants of health. If we allow our discussion to be driven by the commercial determinants of health, we will take away more humanity, whatever is left in medicine. So we need to claim what is our position to bring and install humanities into medicine. That's the individual approach. From an organizational level, I think it's important, not from the perspective of representation. I agree with you, representation doesn't help. If anything, that 60 years of anti-slavery has taught us, representation takes us nowhere. We need to move from representation to belonging, that we, you and me as individuals should belong to the organization, irrespective of our caste, creed, ethnicity, background, country, whatever. It's that sense of belonging where we'll be able to make the dramatic impact that we want to make in these communities. Now, the third perspective is that individuals and organizations need to talk. So what is happening in the last couple of decades is we have extraordinary global health organizations sitting in Montreal, in New York, in Seattle, in Sydney, but they set the debate for the organizations and individuals and communities in the South. I think it's important that individuals in these organizations and organizations of these capacity needs to be in dialogue with the communities that we want to serve. Then only, and by then itself, will be truly and holistically become global. Because health, by definition, is to, the health community is about alleviating the suffering. But that suffering is very parochial if there is no global health in it. And there is no humanities in the global health. And if we strip the humanities from the global health, we'll strip the humanities from the face of Earth. So it's so important from a philosophical perspective that we engage in more discussions like this as we're having today, and really bring back the spotlight that you and me and all of us who are attending this meeting today has a great capacity to contribute by participating, by contributing, and by making sure that our humanities can make a difference. I think that 2 seconds of listening and contributing make a lot of difference. So thank you, Dr. Doering, for a very enlightening discussion. I just want to open the floor with your permission, and if we can invite some comments from our attendees today. And if anyone wants to ask a question, please introduce yourself and do, if you want to put forth your question on a chat box, I'm very happy to read that. But please feel free to put forth your question if anybody has a question. Luciano, if you have a question, you're welcome. You can share some insights from Timor-Leste. So Luciano is the Consul General. My very good friend is the Consul General from Timor-Leste, and he has been one of the right hands of a great Nobel Prize winner, the Nobel Peace Prize of the Portuguese priest who served in Timor-Leste against the oppression of Indonesia. And Luciano da Conceição, he serves as a Consul General in Sydney and has been part of great activism and support for his communities in Timor-Leste. So Luciano, you're very welcome to make a comment, and I welcome you to the meeting as well. You can
hear me,
unmute.
Dr. Sonu?
Yes, we can. We can. Please go ahead.
Good evening, Dr. Sonu, and good afternoon for our friend in Berlin or other part of Germany and other European cities. Well, regarding a topic that we today discussing, or I am taking part of this Zoom meeting, that's something new for me in terms of knowledge. Also, I have no experience this kind of conferences or meeting. I myself, most of my life was given to liberation of my country, or dedicated for the freedom of my country, Timor-Leste. So I am glad for this opportunity that I can be part of that, to have some more knowledge. And please do continue to invite me in the next future, that I could always use my opportunity or make an effort to taking part and to learn from your doctors or experiences or expert involved health issues. Just to make a little correction about my friend Dr. John, that the bishop you mentioned is not a Portuguese, but is a Timorese original bishop named Bishop Bello. Back to 1996 in Germany. If I'm not wrong, it was December 96, one of German largest magazine named the Spiegel, something like that, was having an interview with the bishop about general situation in East Timor. I know East Timor because I was visited German several times and campaigning for independence of my country to the German politicians and other human rights groups, but it was in German, other capital. My first experience visited there, it was in Bonn, not in Berlin, today the capital name. So the interview, Bishop said that Indonesian governments and Indonesian army or authority were treating East Timorese, treating us, the East Timorese people, like a dog. So German people who were reading that magazine, they were said, so why you have to protest to Indonesia? Because they treating you like dog. It's fantastic, because we German or Western people, we love dog. We give the good food, we buy from the supermarket, all good quality, giving it to the dog. So it means that in Western view, Indonesian army or government were treating East Timorese in very good way. But it, in terms of cultural things, it's completely different. In East Timor, or same as Asian country, dog is an animal that people treat it in bad way, not in good way. So that's why in 1997, I was traveling to Germany, in Hanover, Leipzig, and also Dresden, as well as part of other German, and I visited several universities. Few academics asking about that, that after I explained the situation, then German people understood about that. So this is only little things, but our meeting today is about the health issues, global medical things, and so on. So my good friend, Chancellor of East Timor National University, he is also a doctor. He was graduated or did his doctorate here in Sydney University. So please let me know in the next future, this kind of meeting, So I will be very happy to invite him or let him know to participate in order for you that people from third world country who based there and have a knowledge about the world that you are, so he can share an experience about East Timor health system or health condition to you guys, and then we can also learn many things from you as well. I thank you very much, Dr. Sonu, and I thank you, Dr. Ole Doring, that today I can learn many things from you and know more about that very important life of our society, not only for today, but forever and ever.
Thank you, Consul General, and it's always a pleasure, my friend, to talk to you. You bring a lot of humility. I think that particular anecdote from Germany about it just tells you about the cultural differences, and it's so important that we talk to each other. So thank you for bringing that perspective in our discussion today, and it really gives us another way to look at it, that we must and continue to talk to each other. So thank you, Consul General, for coming and joining at a very wee hours on the Saturday evening today. And now I have a question, Dr. Doering, on the chat box from Ming Sun. And she says that, how do you envision a shift from pathogenesis-focused health system to a salutogenesis-based health system? In what areas can this change begin? And for example, what can we do in our capacity as medical students who are currently training to work in this healthcare system focused on tertiary prevention? I think, Dr. Doering, maybe you can answer the first part of the question, and then I will take on the second part, if you will allow me to. Please, over to you, Dr. Doering.
Oh, thank you. This is, of course, a very, very good question. And I think I understand that you're a student yourself, and so I think you are the answer, actually. The curriculum, I think, is the answer, because in the curriculum, we have to bring in the humanities. This is the only way where we can reasonably expect that humanity can enter all these technical programs that medical education now entails. So the simple answer is through the curriculum, but of course it is it's an awareness building process, and we need to do so much more than that. So the first thing is, don't always think about the big pictures. I will just briefly come back to the big picture in a second, but I think the common sense here today is that we need to be humble. So everybody should take the opportunities that present themselves when we are required to listen instead of preaching, or when we're required to pay attention and take care before we make a judgment. All these things might sound extremely trivial and simplistic, but once we are addressed as experts, this communication situation changes and deteriorates into a kind of power game. So I think we need to redefine the relationship between patient, doctors, experts, laypersons, and so on and so forth, not in a way that alleviates the diversity and the differences. We need doctors, we need academics, we need all these experts, but they have to be able to understand what they're doing in the bigger picture. A very good example of this, I think, is this project from the Canadian Medical Association, the CanMeds. They have issued a series of recommendations for interpreting and then building curriculum around this conceptual framework to capacitating medical personnel, caregivers, doctors, and so on and so forth, in a kind of, I think, almost Confucian approach to build the health-giving professions a sense of a social structure where they're playing some roles that are independent and they are switching all the time, and that requires that they reflect on themselves continuously while paying attention to what they owe and what they need. And this is a just an example. As I said, the CanMed is perhaps a good reference for this if you need an example. So I think this is a short part of the answer, and I will not talk about the big picture now because there are two more questions in the chat. And Dr. Bhaskar, you wanted to respond to the second part of the question.
Yeah, no, thank you, Dr. Doering, and excellent question, Ming. And I think that Dr. Doering has touched base on the first part of your question, and I think that the humility to listen is so important. And we can talk about what can be done to embed humanities in a medical education system, but that's a very long-term planning, and that needs more of support from the people in charge of the universities, but also the apex body in Australia and overseas. But from your perspective as medical students, as healthcare professionals, and somebody who is passionate about medicine, I think really getting your experience, hands-on experience on field work is so important in whatever capacity you can. If you can serve in a caregiver environment, or working in a nursing care facility, or going out overseas, getting first-hand experience, you may not be able to provide healthcare services right now, but you may be able to listen and observe the communities there. I think that humility to be a participant or even a witness can be a great step forward in our understanding of developing the salutogenesis aspect of healthcare system that we want to envision. So these are some of my comments, Ming, and thank you for asking the question. Dr. Doering, there's a second question from Shireen. Shireen asks, Shireen is originally from Iran, and but she's currently in Sydney in Australia. And Shireen asks a very poignant question right now. She says, you both touched on the idea that the health inequalities within developed countries are often magnified in developing nations, that this limits our ability to apply our own flawed frameworks onto other countries, and that the best path is asking communities what they need to improve their health. As a medical student who perhaps do not have connections to these communities, and for groups that want to help out but do not have these connections, how do we go about initiating appropriate global health programs? Dr. Doering, if you want to touch on this, or if you want me to answer, I'm very happy to.
Yeah, I think this is more for you, because I could only say something very general here, yes. Like just take the first lead and follow that lead that presents itself to you when you are in your context, because I don't know anything about your concrete situation. Sorry about that.
No, thank you, Dr. Doering. And Shireen, it's a brilliant question. And I think that, we talk about technologies. I mean, technologies is a great enabler, and we can use that technology in both ways. Of course, it also puts some pockets of our communities at that widening inequities in access to healthcare. But at the same time, technology can be leveraged from medical student perspective like yours, that why can't we use the same technology to reach out to these populations? So maybe you may not be physically there, but you can participate in discussions like this as we're having today. This is a great platform to share and shape your ideas that, in times in future, where you will be, in a capacity to deliver healthcare, I think then you would be informed about some of these approaches, and that humility will be part of the way you perceive and deliver healthcare. So leveraging technology to participate in policy-based discussions, to engage in discussions such as this, I think is the way to go. And of course, as a medical student, you also have great opportunities to go overseas and do an internship with the communities, and serving those communities a part of your training and approach. I'm part of a MedAct group in UK, which where we support individuals who are working in the developed country but are from developing countries, to get aware of the programs that are running in these countries, And, you know, there's no dearth of opportunities that you can be part of, doing internships or, you know, shadowing or be a part of a team. And there are a lot of opportunities. I'm very happy to take this forward. And but thank you for asking that question, Shireen. Thank you. Any other questions if anybody has? And if you want to unmute yourself and ask a question, you're very welcome to. Please feel free to put forth your question in the chat box, or if you want to ask a question, you're very welcome to. Dr. Doering, I think that you know, if you want to make some final comments in the interim, I will. So we have another 5 to 10 minutes in our meeting today. So maybe it's the time to make some final comments, and we will wrap up the discussion for the day.
Yes, thank you. I wanted to share with you a remark about an experience that I've been having since this Global Health Initiative was launched, among others, by Dr. Tedros and also our Chancellor Angela Merkel. From the very beginning, I was asking myself, well, what is the added benefit if we introduce a new kind of framework? We have planetary health, we have One Health, we have public health, we have international, and so on and so forth. And I've been asking this question not only myself, but also to all the stakeholders involved in this field whom I could meet. And well, interestingly, and I think this is also something that we personally talked about in the past already, is there's one thing that could actually become an added benefit, and that is if we find a way to bring in all the missing pieces, all the missing perspectives through the humanities into the mission of public health, individual health, and so on, thereby balancing the bias that we have allowed to almost to grow like a cancer into this entire field. The interesting thing is that everybody who I talk to, even the people who are really representative of this existing system, they say, well, this is very important, a very good idea, but we can't do that. Well, they can't change the big ship while it's on its course through the high seas. This is really a pragmatic problem. How can we do that? Everything that is active somehow, be it in the area of the foundations, the engaged caregivers, or wherever, or the policy makers, they all depend on the economics and the conceptual frameworks of this existing flawed system of medicine. That starts with a big rift in the sciences themselves. We were talking about the two cultures of science, which is an invention from the 1950s, Charles Snow, which contradicts everything we have learned from the days of Humboldt about the holistic interdependence. Not only the way we organize, we have good reasons, we have best reasons to see science as a holistic effort, because it's about knowledge, and knowledge has always two directions. One is internal, introspective, and the other is open, outreaching, trying to develop. And we have totally reprogrammed that system so that it will lead into some sort of operating in echo chambers. Now, finally, I would like to bring this to one maybe thesis, and this hypothesis would be that public health extension to global health means to confirm and amplify the structural and conceptual problems, to amplify them, not to redeem them, rather than to be innovative for transforming through humanities. So we need also the discourse about the conceptual framework. I don't think that this will be a new kind of discourse, but it must be a timely one. We know everything, as I said earlier, we have all the knowledge, we don't bring it into the curriculum, we don't bring it into the media, we don't bring it into the communities where it should really make an influence. And this is my hope and my wish that with the help of everybody here today and those who will perhaps join later, that we can really make some difference here. This would be my great hope. In all humility and fully aware of the limitations that we all have. Thank you very much.
Thank you, Dr. Doering, and I think you all will agree that we had a very a very engaging discussion today, and I would like to thank Dr. Doering for joining us from Berlin and bringing his insights and humility about the topic, and I think all of you would agree with the engaging character of the discussion we had today. We touched on a broad range of issues which can be very holistic, but at the same time, we looked at the granularity of those issues as well. And we were not afraid of asking some uncomfortable questions. So I think we have, so it's quite a humbling experience being part of this discussion. Well, some of my final comments to you all are that the global health is not an entity. It's not a topic. It's an experience. It's an experience in humility. And if you as an individual, as a medical student, as a researcher, as a physician, as a community advocate, as an activist, as a stakeholder in this debate who wants to contribute, you have every right and everything in the world to contribute. So please just be part of the team. And I think we as a collective can do so much for patients and our communities that we want to serve. On the final note, I also want to say that in that process, you might have to unlearn, unthink, and sometimes undo some of the lessons you have learned before. To embed humanities back into medicine, we might have to go through a process of revamp. But doing that, we will develop a collective and a deep awareness about ourselves and our patients and our communities. On that note, I want to leave this discussion in your best hands, that I would leave some discussions for you to think about and deliberate in your leisure. But thank you very much for participating in this discussion, and I wish you a very warm weekend and all the best, and stay safe in these difficult times. All the best, everyone.